Hello. Thank you for joining us today. I'm Rita Forden, CEO of the American Osteopathic Foundation, and on behalf of our board of directors, we are honored to be partnering with Dr. Eric Topol's team from the Scripps Research Institute to bring this program to you. As 2020 began to unfold, the foundation collected information, highlighted resources on our website, and sought meaningful ways to be of assistance, thereby providing leadership as COVID-19 gripped our nation. As part of our outreach, the foundation contacted the Scripps Research Institute, who are world-renowned for their innovation and open architectural research studies. We wanted to help them partner and promote and actively participate in their National DTEC study, which stands for Digital Engagement and Tracking for Early Control and Treatment. The goal of the study, which you'll hear more about from both Dr. Topol and Dr. Rayton, is to quickly and accurately identify areas with viral outbreaks through the use of fitness wearables, knowing full well that an early warning affords public health officials more time to take action. By contributing individual health data, participants joined thousands of individuals as citizen scientists. Participants like you and me are not only empowered to take control of our own health, but we can help public health officials curb or even head off outbreaks, including influenza and hopefully COVID-19, within communities where we live and work across the country. The foundation and its network of physicians, student doctors, academics, industry partners, state and specialty affiliates have all been actively encouraging wide audiences to join the DTEC study movement for the past 20 months. This CME training session has been specifically developed for physicians, student doctors, and healthcare staff. The topic, however, is universal and thus applicable to a wide audience. So content can be shared and appreciated by family members, friends, and professional colleagues. Thanks actually to a very generous grant from a research sponsor, this session will be available on demand on the American Osteopathic Association's learning platform throughout this year, as well as the AOF's YouTube channel at no cost to the viewer. We hope you will enjoy watching this educational session as much as we did creating it for you. But please help me welcome our very special speakers from the Scripps Research Institute.
We're launching Detect, and we're really excited about this because this is a way to track from a smartwatch a person's heart rate and to know well before people have fever and symptoms whether there's a cluster of abnormalities that's happening. We can't say whether it's the coronavirus or whether it's influenza, but at least we can see something, predict something very accurately so that we can put an alert. And it's real time, it's continuous, it's scalable, and so we're really very keen on this added ability to be able to detect an emerging problem potentially in any part of the geography of the United States. Well, the problem we have right now is to do tests, whether it's from a body fluid, blood, or any means of actual contact. There's the inconvenience of having to go to a lab or sending a specimen. There's also showing up to a place where other people may get your infection or you get theirs. So what if you could do that from a wristband, just getting things like heart rate? And so we can do that now. We've shown that we could do that as well as the CDC. And so it's an added feature. It's a whole nother way to look at a person's well-being. If they have a resting heart rate, which is abnormal, that could be an early sign, even before there's a fever or any other symptoms, that something's not right, especially when you see a cluster in a community. We have really what's called nowcasting. It's almost like if you were looking at a Google map for traffic. And that's what this is, a real-time assessment, which is superior because in the setting of infectious disease, you could test negative one day and then change the next day. This is real-time continuous assessment. We've been pioneering digital health for about 13 years. I think we were the first program academic in the country. And we learned right straight away is that this sensor world, where you understand the physiology of each person, is an extraordinary way to get a handle, continuous, unobtrusive, and you can, of course, tailor it as you need to for what you're interested in. In the setting of this COVID-19, it gives us a handle on things like heart rate, which we know is a great antecedent abnormality before people get sick. So by tracking people at scale, we'll be able to see an outbreak, as we saw with flu, in a way that previously has not been obtainable.
All right, welcome. My name is Jennifer Radin, and I'm an epidemiologist at Scripps Research with the Digital Trials Center. And I'm going to talk about harnessing wearable data to improve viral illness detection. So to start off, I'm going to give a quick background about our Digital Trials Center at Scripps. And this center is really based off the idea that remote digital trials can be done anywhere and from any time by harnessing smartphones and digital devices that allow participants to join studies from wherever they are through phones and devices that they may already have. And currently we are studying infectious diseases, maternal health, nutrition, sleep, and hopefully many other research topics in the near future. To start off with, I'm going to give a quick background about my research background. I started my career at the CDC with the flu division back in 2009 when the H1N1 pandemic hit, otherwise known as swine flu. And so I was part of the emergency operations team that was tracking H1N1 flu and how it was spreading quickly around the globe. And to give a quick background on how surveillance is done in the United States traditionally, it heavily relies on sentinel sites that are all across the country. And these sites report the number of participants or number of patients that they have that meet a certain case definition. So flu-like illness is often tracked, and that's a syndromic case definition that includes anyone who comes to an outpatient clinic who has fever, cough, and/or sore throat. And so this helps us track kind of viral illness activity over time at the state level. Unfortunately, it doesn't give us a good granular picture on where outbreaks may be occurring locally. So while I was working at the CDC during the H1N1 pandemic, I was involved with aggregating and tracking all the case reports that were coming in from different states that were reporting anytime they found an H1N1 case. And what I found was that there was a huge roadblock, and this roadblock was the fax machine. So anytime a state found a case, they had to fill out this case report form and fax it into the CDC so it could be aggregated and all the numbers could be counted. And as you can imagine, this led to delays. The time that it took for these forms to be sent to the CDC and all the numbers to be aggregated, mistakes are often made when numbers are manually entered into spreadsheets. And it was a very outdated and inefficient system. So there are many different challenges with traditional surveillance. And one of them is there's often a delay that's typically about 1 to 3 weeks from the time someone gets infected, starts feeling sick, seeks care, and all that data is collected by the outpatient clinic and then reported to the state and then makes its way up to the CDC. So we often don't know what's happening at the ground level until several weeks later. This data is often also revised weeks later as lagging data makes its way to the aggregate center. Another interesting thing about traditional surveillance is it can also be influenced by hype, also access to care. So if there's a lot of media reporting about a pandemic or an outbreak, people may be more likely to go to their doctor if they have a cough or a common cold symptom, just to make sure that they don't have this virus. So during the time while I was at the CDC, there was many novel digital disease surveillance systems that were starting to be explored. One of them was Google Flu Trends. So anytime someone Googles or searches for, say, cough or sore throat or any cold-like symptoms, this can be aggregated at a huge population level, and it can give a good tracking metric of kind of when viral illness may be peaking or increasing in a population. And so, although this is can provide much faster, more real-time information as to what's happening, there have been some studies showing that Google Flu Trends also often overestimates peaks, likely due to that media hype. So more people searching for these terms, even if they're not sick, because they're reading about them in the news. Another digital method that has been used is looking at Twitter data. So anytime someone tweets about flu or cold-like symptoms, that data can also be collected and aggregated. And again, both of these methods can provide more real-time, faster data on what's happening at a population level compared to the traditional surveillance that is done at the clinical level. So during the COVID-19 pandemic, similarly, there was also a big roadblock to collecting and aggregating data. And this roadblock actually happened to also be the fax machine. So during the beginning of the COVID outbreak and pandemic, the US actually had to bring in the National Guard to help manage and deal with all the faxes that had to be sent to collect data of case reports that were occurring all over the country. And again, this is a very outdated way of tracking viral illness surveillance. So when I joined Scripps and the digital research team with Scripps Research, I started to wear an Apple Watch and to track my own heart rate and activity and sleep data over time. And I was really interested because I noticed my own data on the left. I had a very stable and constant resting heart rate that was usually about 60 to 63 beats per minute. And the population average that's considered normal is 60 to 100 beats per minute. So that was well within the normal average. And on the right, I noticed when I got sick and came down with a flu-like illness, my heart rate spiked to 77 beats per minute. And while 77 beats per minute is still within that population average that's considered normal, it was outside of my own individual normal value. So that gets into what is normal for an individual. Again, population average is 60 to 100 beats per minute. People often go to their healthcare provider and they will listen to their heart rates and measure their heart rate during this one time, which is often kind of an artificial representation of what their normal is. People are often nervous, they're running late to their doctor's appointment, so this likely is not a good representation of what their actual value is. And what is healthy for sleep and steps is also something that's kind of hard to quantify. So it's recommended that people get about 7 to 9 hours of sleep a night. There's also often cited that people should try to get 10,000 steps a day, although there's limited research to support that specific number. So my group at Scripps, we were lucky enough to have access to a data set of Fitbit users. It was 200,000 Fitbit users who wore their Fitbits for about 2 years. And this data set was very interesting because it helped us look at what is a normal amount of sleep and activity and heart rate. So one of my colleagues looked at kind of answering this question, what is the typical amount of sleep? And they found that there was huge variation across the population. So some people slept as little as 4 hours and some people slept over 9 hours. And they also found that the mean sleep duration actually varied by gender and also body mass index. One of my other colleagues, Dr. Quer, also looked at change in resting heart rates. And he found that, again, everybody's resting heart rate is relatively unique to them, that their heart rate varied only a little bit from week to week, just about 3 beats per minute. But between individuals, resting heart rate could vary quite substantially from as low as 40 beats per minute to over 100 beats per minute. And he also found that there were some differences, again, by gender and BMI and sleep. So when he was looking at this data, he also, how I found with my individual data, that there are some times where individuals had these spikes in their resting heart rate. And we think that this may indicate that they had some sort of viral illness. So I also looked at this 200,000 Fitbit users in this data set. And due to my background with infectious disease surveillance, I was curious to see if we could aggregate this data at a population level and use it to improve surveillance, real-time surveillance. Their heart rate and sleep when they're normal, so 1 or half a standard deviation above normal. And then I took the proportion of users each week who had this abnormal data. And I found that this variable significantly improved our ability to predict real-time flu-like illness surveillance at the state level. And as you can see, we looked at 5 states where we had the greatest number of Fitbit users. And again, it was significant in each state. So this was really exciting because in the United States, there's this huge growth of wearable use. So it's predicted that wearable use will be about a quarter of the population by this year. And there are some differences across different subpopulations on who's more likely to use a smartwatch or a fitness tracker. So slightly more representation of women, certain race, ethnicity backgrounds, typically younger populations, more educated populations, also more people who have a greater income and more likely to come from suburban locations. So there are some challenges when using wearables to conduct research, and as these devices become cheaper and cheaper over time, we expect that there'll be continued growth of their use and hopefully more accessibility to all populations who are interested in using them. So when the COVID pandemic hit nearly now 2 years ago, we decided to launch our study called DETECT. And so DETECT is a digital research study where we are harnessing data from smartwatches and fitness trackers. And so in order to join DETECT, you can download our research app, which is called My Data Helps. And this app is available in both Apple and also Google Play. And this research app allows participants from all over the country who are over 18 to join our study. There's an e-consent, which explains what our study is hoping to look at. And these participants can then share their data from fitness trackers. And so we're device agnostic. We can pull in data from Fitbits, Garmin's, Apple Watches, Withings, any device that connects to Google Fit or Apple Health Kit. And we currently have over 39,000 participants from all over the country, definitely more right now in California, but we're hoping to really expand that number across the country to hopefully create a platform where we can look at deviations in people's sensor data to identify hotspots of viral illness activity. Let's see. And so, as I said, again, we can pull in wearables, sensor data from any wearable that connects to HealthKit or Google Fit. We're even right now trying to also incorporate new research apps that allow participants to take their heart rate through the camera on their smartphone. So that might even open up our research study to more people who may not have access to a fitness tracker. And right now, we have a pretty diverse population, definitely more people in the 30s and 40s, more females than males, but we're still hoping to really increase our diversity and increase our representation in all different geographies across the country so that we can better track viral illness activity. So people often ask me, how accurate are these consumer wearables? And there have been a number of different studies that have shown that, especially when looking at resting heart rate when someone's not moving, they do a pretty good job compared to kind of gold standard measurements for tracking heart rates. So now I'm going to get into some of the research studies that our team has done with the Detect data. And one of the first things we hoped to look at was whether we could use the data from wearable devices to better screen people who may be more likely to have COVID versus another viral infection. And so early on in the pandemic, and even right now, fever is often used as a screening technique to identify whether someone should enter an office building or whether to screen a child as they go to school. However, we know from many of different research studies on COVID already that fever is actually only occurs in about 30 to 40% of COVID patients who go to the hospital. However, tachycardia or a rapid heart rate is actually potentially a better way to identify viral illness infections such as COVID. So my colleague, Dr. Queer, completed this study early in October of last year, and he found that this study was based on a prior study done by a different group, and they found that there are certain self-reported symptoms that were really useful for identifying whether someone had COVID infection versus another viral infection. So symptoms such as loss of smell and taste were especially useful for differentiating whether you had COVID or a different viral infection. So Dr. Queer found that when you add wearable data into this algorithm, you could do an even better job of differentiating whether someone fell into the COVID bucket or the other viral illness category. And we ended up getting an area under the curve of 0.8. So this does a pretty good job of differentiating whether someone has COVID. And this can be very useful, again, during a time when we are relying on not very good screening techniques, such as taking someone's temperature or asking if they have symptoms when they enter a building. Again, since 1 in 3 people are also asymptomatic, these methods don't do a great job of screening people. So we believe that if you incorporate wearables, you can potentially do an even better job of identifying who's at high risk for infection and potentially testing those people and screening them better. So more recently, our group did a study on long COVID. And so what we did was we used the sensor data to see how long it was taking individuals to return to their baseline after they came down with a COVID infection. So on the left-hand side, we compared individuals who are COVID positive versus those who had tested negative, but were still symptomatic of some sort of viral infection. And as you can see, the top left figure is looking at resting heart rate. There was this initial kind of spike in individuals' resting heart rate when they first had symptoms for COVID. And then interestingly, there was a short period where their heart rate dropped. And we think this is related to some sort of autonomic nervous dysfunction. And then individuals' resting heart rate went back up and stayed elevated for about 2 to 3 months. Same with looking at sleep and steps. We saw this initial spike in steps, but it came down a lot faster and went to their baseline a lot faster, and same with sleep. And then on the right-hand side, we kind of grouped COVID positive individuals into 3 groups based on their average resting heart rate during the 2nd month after their symptom onset. And what we found was interesting that some individuals' resting heart rate went up and then remained elevated for a very, very long time, whereas some individuals, their resting heart rate went up, but then came back to baseline a lot faster. And so we think that this may also reflect individuals who go on to develop long COVID. And we think that in the future, wearables can help clinicians track long COVID and how long it's taking their patients to return to baseline, and also potentially track who is developing autonomic nervous system dysfunction as a result of contracting COVID. So we have also recently, we published, this paper is actually in meta-archive right now, but we're working on a paper to look at physiological response to vaccines, to COVID vaccines. And so this paper, we looked again at comparing each person's self to their baseline prior to getting the vaccination. And we found some interesting results here as well. We found that on the top, we looked at individuals who had a previous infection to COVID before they got vaccinated. And we found that this group had a much larger initial resting heart rate response to vaccination compared to the group that had never had COVID vaccination before getting, or never had a COVID infection before getting vaccinated. We also compared Moderna to Pfizer, and we found that individuals who received the Moderna vaccine had a much larger resting heart rate response. Overall, we also found that heart rate response was a lot larger for the 2nd dose compared to the 1st dose. So this kind of reflects a lot of the symptoms people are experiencing as well, where they're more severe or more responses to the vaccine after their 2nd dose, where they feel achy or more feverish. But what we're hoping is in the future, we can also collect different markers of immune response. So we could compare, say, physiological response to antibody response. So we think there's potential for using wearables to help track how well someone's responding to a vaccine and whether they're mounting a sufficient immune response. So recently, my colleague, Dr. Quare, also published a study looking at whether you can also use passive detection of COVID with wearables and machine learning algorithms. So this study was actually similar to the first one that we studied. However, this one showed that if you look at individuals, including those who are asymptomatic and pre-symptomatic, and if you exclude symptoms, you still can do a pretty good job of identifying whether someone has COVID versus another viral infection. And so this is really exciting for creating kind of this passive surveillance system, which really doesn't require much input from participants, where we can just look at their sensor data and be able to have a pretty good idea whether they have COVID versus another viral infection. So again, all of this work has also been validated by many of our other colleagues across the country and across the world who are looking at wearables and validating the value of using wearables to track viral illness infection. And so there's been now even more studies enlisted here, but our colleagues have looked at changes in individuals' temperature during infection, looking at whether you can identify if someone has infection before they have symptoms. There's, our colleagues at Fitbit looked at whether physiological data could help predict kind of severity of illness, and many others, also looking at population viral illness detection. And so this really just shows the potential and value of using these sensors, consumer wearables, to both inform the individual on screening and also at a population level to help track viral illness activity, not just COVID, but other viral illnesses as well, such as flu in the future. So there's huge value in this data. And as we go forward with the DETECT study, we really want to increase our participant size across the country, really enroll a diverse and representative population so that we can aggregate this sensor data at a population level and better understand how sensor data fits in with all these different other really important layers of surveillance data. And so we think that when you combine all these layers, such as wastewater surveillance, vaccination coverage, rapid testing results, Google search trends, and hospitalization utilization, we'll be able to better understand kind of where a population fits with viral illness activity, whether trends are increasing, how much care has been being utilized at a time point, and hopefully be able to identify outbreaks and pandemics a lot faster than currently we're able to using only traditional surveillance means. And so, as you all know, resting heart rate is a very non-specific vital sign. So your heart rate can go up for many different reasons. If someone, say, drank too many glasses of wine the night before, if they are very stressed or perhaps dehydrated, many different factors can influence your heart rate. But as these sensors evolve, we're finding many new metrics are also being incorporated and added into these wearables, such as temperature and respiration, pulse oximetry, cough analysis, blood pressure, sweat analysis, and even sensors for children. So in the future, our algorithms will likely improve over time as we get all these new metrics incorporated and hopefully be even more specific for identifying a viral illness versus another cause that's impacting someone's health. And finally, I'd say that our all this research couldn't be possible without an amazing team that has actually pivoted for many other research projects to help work on this pandemic COVID-related research project. And so it really wouldn't have been possible without them and all of our research partners across the country. And so finally, I encourage all of you to check out our website, detectstudy.edu, and encourage your friends and family and patients to enroll in our research study. by downloading our research app, My Data Helps. Again, it's a very easy research study because it can be done from the comfort of your home. Participants can be a part of it whenever and wherever they would like to. Very simple. The research app, you can share your symptoms, your vaccination status, whether you got test results, and also your sensor data. We also have the ability to connect to electronic health records as well, so we can look at different health-related outcomes related to viral illness infection and even non-viral illness infections. So there's huge opportunity with this data to look at individualized health and also population health. So thank you for your time, and again, please join our study.
We moved into a digital world in medicine, and in the last decade, we finally had the realization that clinical trials and medical research could be completely rebooted.
Technology explosion and revolution that hit computers, that hit cell phones, has also hit digital health.
It's progressing so that we can get closer and closer to being able to allow people to participate in biomedical research from the comfort of their own home.
The fact that the center is an open source, so different researchers can access the data that we have here and advance the medicine, advance the science.
The purpose of the center is really to be at the forefront of innovation, both on the digital sensor side and direct-to-participant research.
The tech, which was the first mobile app study developed in March of 2020, that quickly enrolled tens of thousands of participants.
A large population like this help us understand really new things that we could not do before.
With multi-layered data, we should be able to prevent conditions that otherwise a person would be at risk for. That's fulfilling a fantasy of prevention that we've never been able to attain before.
I don't know of any other research institution or group that is truly bringing participants as partners, that's meeting them where they are, that's only going to improve your retention, your engagement, and the outcomes that you have.
Our partnerships stem from the fact that we recognize we cannot do this by ourselves.
They come to collaborate at Scripps so that we can do life-changing things together.
These are huge, complex problems that we're trying to answer.
And we can do these things at scale, at an efficiency level that's unsurpassed. So I think that is the future of a large proportion of medical research.
The evolution is both in form factor, the shrinking of the technology, but the information also that it provides back, the power that it provides back to an individual.
Understanding your own health can only lead to better care for you.
So why would people ever have to go in the hospital? They should be in their home, and they would have sensors and multi-layered data to keep them safe. This ability to capture data at multiple levels and analyze it in real time, it's a movement, and it's just getting started.